Assalamu alaikum. Our next lecture is about antimetabolites. Antimetabolites are also categorized into the cytotoxic agents, which are included in anti-cancer drugs. And in previous lecture, we have discussed about the antimetabolites, their some phase specificity, that is, they are as phase specific, and they are subdivided into three main groups, that is folic acid, pyrimidine, and purine. As the name indicates, metabolites are the agents which are important, which are essential in the process of synthesis of DNA. And these agents are folic acid, these agents are pyrimidine bases, and these agents are purine bases. So we know the pyrimidine and purine bases consist of cytosine, thymine, and uracil, which is under the umbrella of pyrimidine, and others are adenine, guanine, and hypoxanthine, which are under the umbrella of purine. And folic acid, the folic acid, the activity of folic acid during the synthesis of RNA and DNA, that is, it activates the tetrahydrofolic acid, which is the main agent required required in the activation of folic acid. So these are the metabolites which are required. And if the anti-cancer agent interrupts the cell cycle of DNA synthesis at this level, at the metabolite level, the drugs are considered, and categorized in the category of antimetabolites. Antimetabolites, basically the structural analog of important natural metabolites, and they are able to disrupt critical metabolic processes in which they inhibit enzyme that synthesize essential cellular constituents. These drugs are as phase specific, as I told you earlier, and they can act during any phase of the cycle except G naught, that is the resting phase. The classification is folic acid analog, pyrimidine analog, and purine analog. While come towards the folic acid analog, we have seen the folic acid is needed for several essential biochemical reactions. Folic acid analog block the conversion of folic acid to its active form. Uh, that is, the analogs are required to block the conversion of folic acid into its active form. And there are three main analog which are used as anti-cancer, that is methotrexate, pemetrexate, and pralatrexate. These folate analog are used to treat bacterial infection. Other than these three are trimethoprim, is used to treat malaria, pyrimethamine, and Pneumocystis jirovecii pneumonia trimethoprim. Now come towards the anti-cancer agent. As we have discussed only the anti-cancer agent and not the treatment of infections, but for our knowledge and consideration, that methotrexate is not only therapeutically used as anti-cancer agent, but also non-cancer diseases, in which include the rheumatoid arthritis, okay, Crohn's disease, and psoriasis, and also during the abortion. So these are the non-cancer application of methotrexate. As soon as we have discussed the mechanism of action, the mechanism of action of methotrexate is directly inhibit the dihydrofolate reductase, an enzyme which convert dihydrofolic acid into tetrahydrofolic acid. Because the production of tetrahydrofolic acid is necessary step in the activation of folic acid, that's why activation of folic acid is required for biosynthesis of essential cellular constituents, that is DNA, RNA, and protein. And its inhibition, the FH4 production inhibition, has multiple effects on cells. Um, these It is also involved in the suppression of reduction of FH4 availability, and the biosynthesis of thymidylate appears most critical because in the absence of thymidylate, cells are unable to make DNA. And in this sequence, cell kill results primarily from disrupting DNA synthesis. Methotrexate is considered as S phase specific. So the S phase, that is during the DNA replication and DNA strand replication, the methotrexate has beneficial effect. Fall in thymidine level caused by methotrexate is a potent signal for inducing apoptosis. That is, apoptosis means the programmed cell death. Now, a precaution which is very much needed during the treatment by methotrexate applied, that is the um, leucovorin rescue, because the methotrexate effects are very high, and it also promotes the normal cells into uh, at risk. So to cover the risk, to save the risk, leucovorin, that is a citrovorum factor, and it is also known as folinic acid, is given, and it bypasses the metabolic block caused by methotrexate, thereby permitting normal cells to synthesize thymidylate and other compounds. While on the other sides, malignant cells are not safe to the same extent because leucovorin uptake requires the same transport system employed for methotrexate uptake. So, the transport system these cells lack, it should be noted that leucovorin rescue is potentially dangerous. Failure to administer leucovorin in the right dose at the right time can be fatal. So, it is very important while during the uh, therapy done by methotrexate, leucovorin rescue should be administered. That is the folinic acid, so that the normal cells reuptake the thymidylate and undergo the normal mitotic phase as compared to cancer cells. The pharmacokinetics of methotrexate is now as it can be administered per oral, intramuscular, IV, and intrathecally. The drug is highly polar, and transport system is needed to enter mammalian cell. Cancer and normal cells, both methotrexate undergo enzymatic activation to a polyglutamate form. Elimination is renal, while in case of renal impaired patients, doses must be reduced to prevent the drug from accumulating to toxic level. Because methotrexate is highly polar, it crosses the blood-brain barrier poorly, except when given in very high doses. So, ensure effective levels, intrathecal administration is employed in most of the CNS cancers. The resistance for methotrexate developed due to different mechanisms, and these are decreased uptake of methotrexate. It might be increased synthesis of dihydrofolate reductase, or sometimes the synthesis of a modified form of dihydrofolate reductase that has a reduced affinity for methotrexate. Most of the time, increased production of a transporter that pumps methotrexate out of the cells, and commonly reduced production of enzyme needed to convert methotrexate to its active form, that is polyglutamate form. As soon as the indications of the methotrexate covered in the carcinoma, it is more associated with in women with choriocarcinoma, and it is also active against non-Hodgkin's lymphoma, acute lymphocytic leukemia of childhood, and uh, as we have discussed, the leucovorin rescue is very much needed. And during the head and neck sarcoma and osteogenic sarcoma, its need is become very high. Non-cancer application, as we have discussed earlier, that is rheumatoid arthritis, psoriasis, Crohn's disease, and Boston. While discussing the toxicity of the methotrexate, it is highly toxic at bone marrow suppression, pulmonary infiltrates and fibrosis, oral and GI ulceration. Death may also reported due to intestinal perforation and hemorrhagic enteritis. Nausea and vomiting may occur shortly after administration. High doses can injure the kidneys. To promote drug excretion, thereby minimizing renal damage, the urine should be alkalinized and adequate hydration maintained. And methotrexate has been associated with fatal malformation and death. That's why it is not given during the pregnancy and avoided at least 6 months after completing treatment. Pregnancy should be avoided at least after completion of the treatment, at least 6 months after the completion of treatment. Now, the next drug is pemetrexed. Pemetrexed, the mechanism of action and other its clinical uses, kinetics, and toxicity. Before we have discussed the pemetrexate and other drugs, I want to show you the diagram in which you have understand the mechanism of action of methotrexate at this level. That is, it inhibit the dihydrofolate reductase, the enzyme which is involved in conversion of dihydrofolic acid to tetrahydrofolic acid. And this tetrahydrofolic acid is very much needed to in the process of thymidylate synthesis and thymidylate synthesis, as well as the activation of folic acid, which is required in the synthesis of DNA. At this moment, methotrexate inhibit this enzyme, and by the inhibition, there is a somehow decrease or decline of folic acid in the normal cells. So leucovorin rescue is needed here in this phase, which then folinic acid convert into N5N10 methylene FH4, and skipping the step in which we inhibit the enzyme dihydrofolate reductase. This N5N10 methylene FH4 is then required for thymidylate synthase. And at this level, the other anti-metabolite, which is included in pyrimidine analog, basically named as fluorouracil, this inhibit this thymidylate synthase, and it inhibits the or it suppresses the production of thymidylate. So both these and metabolites, that is thymidylate and folic acid, are required for the DNA synthesis. And at one level, methotrexate affects the synthesis of DNA, and on the other level, that is the level of thymidylate, the fluorouracil inhibits the production of thymidylate and ultimately the synthesis of DNA. So both these drugs are highly effective and most commonly used in cancer regimes, anti-cancer regimes. Now come towards another drug which included in a folic acid analog, and that is um, pemetrexate. Here it is. Pemetrexate action has an antifolate compound. Its action similar to methotrexate, and it inhibits dihydrofolate reductase. It also inhibits two other enzyme, thymidylate synthesis and glycinamide ribonucleotide formyltransferase. All these enzymes are involved in de novo synthesis of thymidine and purine nucleotide. By inhibiting these enzymes, pemetrexate can suppress synthesis of DNA, RNA, and protein. Cell death results primarily from disrupting DNA synthesis and function. Pemetrexate is considered as phase specific. The therapeutic uses of pemetrexate is in combination with cisplatin, and it is approved for IV therapy of unresectable malignant pleural mesothelioma. And it is a rare type of cancer which is usually associated with asbestos exposure. The monotherapy is approved for non-small cell lung cancer after previous chemotherapy, and for initial therapy of this cancer and combined with cisplatin. Investigational uses include gastric, pancreatic, and breast cancer, but not developed till yet. The kinetics involved, the administration is IV, like methotrexate, and it undergoes conversion to active polyglutamates within cells. Compared with normal cell, cancer cells are more efficient at polyglutamation. Cancer cells are most likely to be harmed, and pemetrexate is eliminated by renal excretion. In patients with renal compromise, the elimination half-life is 3.5 hours, and in patients with renal impairment, elimination is delayed. The toxicity include bone marrow suppression, GI disturbance, skin and rash, and fatigue. And to reduce bone marrow and GI toxicity, patients should receive prophylactic doses of vitamin B12 and folic acid starting 1 week before dosing. To reduce skin rash, patients should receive polyphylactic glucocorticoid, that is dexamethasone, and it can also cause fatal malformation and death, so it should not be given during pregnancy. And extravasation is managed as it would be for other non-vesicants. The drug is not a vesicant. Now, the next drug is pralatrexate. Pralatrexate um, include in the same folic acid analog, and it's similar structure with methotrexate, and it also inhibit dihydrofolate reductase, again disrupts the synthesis of DNA and essential cellular components, result is cell death. Pralatrexate can be considered as S-phase specific therapeutic use. It is only used, it is have only one indication and only used in IV treatment of relapsed or refractory peripheral T cell lymphoma. Other uses, which is relatively rare and often aggressive form of non-Hodgkin lymphoma, and in clinical trials, the minority of patients responded, but in some patients who did respond, the response duration was substantial. So the pharmacokinetics is IV push, and it bound to plasma protein about 67%. And like methotrexate, the drug undergo metabolic conversion to active polyglutamates within cells. Elimination is renal, and in renal impairment patient, dosages should be reduced to avoid toxicity and drug accumulation. The toxicity associated with this drug is GI mucositis, bone marrow suppression, manifesting as thrombocytopenia, anemia, and neutropenia. And to reduce toxicity to the GI mucosa and bone marrow, patients should receive prophylactic doses of folic acid and vitamin B12. Other toxicities occurring in 30 to 40% of patients, including fatigue, nausea, vomiting, constipation, edema, fever, and cough. The drug is embryotoxic, so it is included in the pregnancy risk category D, and it should not be given in pregnant women unless the woman outweighs the risk to the fetus. Women receiving the drug should be advised not to get pregnant during the therapy. The other classification of drug is pyrimidine analog. And pyrimidine analog, as we have discussed earlier, the pyrimidine, cytosine, thymine, and uracil are the bases employed in the biosynthesis of DNA, RNA. These the analog of pyrimidine have the structural similarity to naturally occurring pyrimidine, that is, both are similar, and they can act in several ways by inhibiting the biosynthesis of pyrimidine, by inhibiting the biosynthesis of DNA and RNA, and undergo incorporation into DNA and RNA. So the disruption of nucleic acid function, and these all analogs which is associated with pyrimidine analog are product that must be converted to their active form in the body. So we have five pyrimidine analog, namely as cytramine, fluorouracil, capecitabine, floxuridine, and gemcitabine. Now we have discussed these five pyrimidine analog one by one. Cytramine, cytramine basically is ARA-C, also known as ARA-C, and it is the analog of cytosine, so it is also known as cytosine arabinoside, and it is an analog of deoxycytidine. Drug has established its role in treating acute myelogenous leukemia, that is AML, and the drug is available in two formulation, that is conventional, which has a route of administration is IV and subcutaneous, while the liposomal cytarabine is used as intrathecal dosing. Mechanism of action of ERA-C is very clear by undergo incorporation into DNA by a mechanism that is not fully understood. Incorporation suppresses further DNA synthesis. ARA-C may also impede DNA synthesis by a second mechanism, that is the inhibition of DNA polymerase. So the drug is categorized into S phase specific. Resistance developed by major causes, which include the decreased uptake of cytarabine, increased conversion of cytarabine to an inactive product, and increased production of DCTP. Again, the kinetics is IV, subcutaneous, and intrathecal, which we have discussed. That is the two forms. Cytarabine is not active orally, and the cells take the drug, undergo rapid demyelination in the liver, metabolites are excreted in the urine. Therapeutic uses, it is used conventionally in AML, acute myelogenous leukemia, and to induce remission, the drug is combined with idrabucin as part of the so-called 7 plus 3 regime, that is 7 days for cytarabine and 3 days for idrabucin. Other applications include ALL, that is acute lymphocytic leukemia, the non-Hodgkin's lymphoma, and additionally liposomal cytarabine is used to treat lymphomatous meningitis. Again, the toxicity is bone marrow suppression, as in all the drugs which we discussed in categorized into anti-cancer agent, that is neutropenia, thrombocytopenia, and anemia. And nausea vomiting is also associated with the application of cytarabine, especially after IV bolus injection. Other toxicities include stomatitis, liver injury, conjunctivitis, and high doses may also cause pulmonary edema and cerebral toxicity. While the lipid formulation, that is liposomal formulation, can cause chemical arachidoiditis, manifesting as nausea, vomiting, headache, and fever, left untreated, the condition may be fatal. Incidence and severity of the reaction can be reduced by co-administration of dexamethasone and inflammatory glucocorticoid. This is very important here to understand that to prevent or to treat the adverse reactions associated with anti-cancer agent, most of the time glucocorticoid, which has an anti-inflammatory activity also, and most commonly the dexamethasone is used in as co-administration. The other important drug is fluorouracil. Fluorouracil is another derivative, is the fluorinated derivative of uracil, and the ड्रग इज एम्प्लॉयड एक्सटेंसिवली टू ट्रीट सॉलिड ट्यूमर्स द मैकेनिज्म ऑफ एक्शन जैसे कि हमने डायग्राम में देखा था as we have seen in the diagram to exert cytotoxic effect fluorouracil must be converted to its active form that is 5-fluorodeoxyuridine 5 monophosphate FDUMP FDUMP and FDUMP inhibits thymidylate synthetase thereby depriving cells of thymidylate needed to make DNA. Fluorouracil is actively against only the cells that are undergoing through the cell cycle, so it is S phase specific. The resistance developed due to the decreased activation of fluorouracil and production of altered thymidylate synthetase. And the therapeutic uses include it is limited to solid tumors, which include breast and colorectal cancers, and palliative therapy of carcinomas of the colon, rectum, breast, stomach, and pancreas. This fluorouracil topically used to treat pre-malignant keratosis. The kinetics administration is IV. CIV is more effective, less toxic than bolus administration. This widely distributed and enters in the CNS with ease, elimination by rapid hepatic metabolism. The toxicity include the bone marrow suppression and GI ulceration. To minimize the GI injury, the fluorouracil should be discontinued as soon as mild reactions occurs, and doses may be limited by palmar plantar erythrodysesthesia, the head and foot syndrome, characterized by tingling, burning, redness, flaking, swelling, and blistering of the palms and soles. So this is another different adversity which we observed in during the treatment of fluorouracil. Point to be noted here. Other adverse effects include alopecia, hyperpigmentation, and neurologic effects. In patients given a fluorouracil overdose treatment with an investigational antidote, that is uridine triacetate, can be life-saving. Uridine triacetate is a product that undergoes conversion of uridine, which then dampens the effect of fluorouracil on cellular metabolism. The other drug is capecitabine. Now, capecitabine is a product form of fluorouracil indicated for oral therapy of metastatic breast cancer as well as colorectal cancer in both the adjuvant and metastatic settings. Capecitabine again undergo the metabolic conversion to fluorouracil and then to FDUMP and then its active form. The capecitabine is very much likely to fluorouracil. The cell death occurs due to inhibition of thymidylate synthetase. Capecitabine is only given during the division of the cells like fluorouracil, so it is also S phase specific. Most of the patient in clinical trials with breast cancer experience at least a 50% decrease in tumor size while during the investigation, and severe diarrhea is common and can be dose limiting. Other common side effects include nausea, vomiting, stomatitis, and again, which we observed head and foot syndrome in the fluorouracil, as same as in the capecitabine, and this head and foot syndrome characterized by local tingling, numbness, pain, swelling, and erythema of the palms and soles. Capecitabine is a teratogen, and it should not be used during pregnancy. Drug can also cause leukopenia. A myelosuppression is severe and it is uncommon. Alopecia has not been reported. Capecitabine enhances the effect of warfarin, the important drug interaction, uh, and it can reduce the risk of bleeding. Anticoagulant effect should be monitored closely and warfarin dosage reduced as indicated. In patient with renal impairment, capecitabine accumulate to the toxic levels. So, if renal impairment is moderate, dose should be reduced to 75%, and if the renal impairment is severe, drug should not be used. Another drug is floxuridine, which is very similar to fluorouracil. The mechanism of action is same. Uh, the effects are identical, and it is indicated in GI adenoma metastatic to the liver. Drug administration is infusion directly into the hepatic artery, and dose limiting toxicities included again same bone marrow suppression and GI ulceration. The last drug is gemcitabine in this class, that is pyrimidine analog, and it is nucleoside analog that inhibits DNA synthesis. It is also S phase specific. It is converted into two active form, that is gemcitabine diphosphate and gemcitabine triphosphate. The gemcitabine diphosphate inhibits ribonucleotide reductase, an enzyme needed to form deoxynucleotide triphosphatase, which are required for DNA synthesis, and gemcitabine triphosphate undergoes incorporation into DNA where it inhibits strand elongation. The indication for gemcitabine is advanced ovarian cancer, metastatic breast cancer, adenocarcinoma of the pancreas, non-small cell lung cancer of the lung. And for pancreatic cancer, the drug may be used as first-line therapy in patients with locally advanced or metastatic disease and in patients previously treated with fluorouracil. In clinical trial, gemcitabine reduced pain, improved functional status, and prolonged life slightly. The toxicities associated with gemcitabine, it can cause a wide variety of adverse effects, which is fairly well tolerated, including the myelosuppression, nausea, vomiting, and elevation of serum transaminase in occurs in 75% of the patients. About 20 to 45% of patients develop proteinuria, hematuria, pain, fever, rash, and flu-like syndrome. And less common reactions include diarrhea, constipation, stomatitis, dyspnea, paresthesias, edema, alopecia. Infusion reaction, for example, hypotension and flushing, may occur and can be managed by slowing the infusion. Now come towards the next class, which is purine analog, uh, under the umbrella of under the umbrella of again antimetabolites. And like the pyrimidine, the purine bases, that is adenine, guanine, and hypoxanthine, are the bases employed for the basis of biosynthesis of nucleic acid. And these purine analog are discussed here, and they are used in the treatment of cancer. They are considered as cladribine, clofarabine, fludarabine, mercaptopurine, nilarabine, pentostatin, and thioguanine. The um, um, purine analog also used as immunosuppression and antiviral therapy and gout. Now, for the anti-cancer activity, we have to discuss these drugs one by one. First of all is mercaptopurine. Mercaptopurine is a prodrug basically in considered in the purine analog, and it undergoes conversion to its active form within cell. After the activation, the drug can disturb the multiple biochemical processes, including purine biosynthesis, nucleotide interconversion, and biosynthesis of nucleic acid. All the actions probably contribute to cytotoxic effect, so it is S phase specific, and resistance occur due to the reduced activation of the drug and accelerated deactivation. The kinetics is oral, that is, the administration is oral, undergo erratic absorption. Absorbed drug is distributed widely, but not to the CNS. Metabolism is by liver, and by an important reaction is catalyzed by xanthine oxidase. So, the patients receiving a xanthine oxidase inhibitor, that is allopurinol, mercaptopurine dosage should be reduced. The indication for mercaptopurine is used as maintenance therapy of ALL, that is acute lymphocytic leukemia, in children and adults both. The dose limiting toxicity is again bone marrow suppression, and mild hepatotoxicity also manifest at the levels in bilirubin and liver transaminase, which is relatively common. So, hepatic injury progresses to fatal liver failure, and other adversities include nausea, vomiting, oral intestinal ulceration. While during the use of xanthine oxidase inhibitor, it increases the overall toxicity. The mecaptopurine is mutagenic, so must not be used during pregnancy. Avoid it during the pregnancy. Another drug is thioguanine. Thioguanine is much as similar as mercaptopurine. Their mechanism of action is same. Their indications is somewhat different. That is, mercaptopurine is used for ALL, while thioguanine is used for acute non lymphocytic leukemia, that is ANLL, and it is also as phase specific. The kinetics is oral, again, absorption is erratic and incomplete, and activation by hepatic metabolism does not distribute it in CNS, but due to hepatic metabolism, the xanthine oxidase um, inhibitor is being used. No dose reduction is required if a xanthine oxidase inhibitor is being used because thioguanine is not degraded by xanthine oxidase. The toxicity is again is same as mercaptopurine, that is bone marrow suppression and GI reaction, while liver injury as cholestatic jaundice may occur, but not as severe as during the mercaptopurine. Now come towards pentostatin. Pentostatin is an analog of adenosine, and it the drug is acts in two major ways. That is, it inhibit adenosine deaminase, causing accumulation of adenosine and deoxy adenosine nucleotide, the compound that inhibit ribonucleotide reductase, and thereby block DNA synthesis. The second is pentostatin promotes accumulation of S-adenosyl homocysteine, a compound that is especially toxic to lymphocytes. So the drug only approved indication is hairy cell leukemia, and that has not responded to interferon alpha. The toxicity include bone marrow suppression and CNS depression. Other toxicities include nausea, vomiting, rash, and fever. While the fatal pulmonary toxicity is also reported, so not recommended during the pregnancy. The administration is IV bolus or IV infusion. The next drug is fludarabine. Fludarabine is an analog of adenosine, highly indicated during the chronic lymphocytic leukemia, that is CLL, low grade non Hodgkin lymphoma, and acute myelogenous leukemia AML. IV administration is recommended. Life threatening autoimmune hemolytic anemia has been reported during the uh, administration of fludarabine. Major dose limiting toxicity is bone marrow suppression again, and the GI complication, including nausea, vomiting, and chills. Uh, at normal doses and especially in excessive doses, fludarabine can cause severe CNS effect, including blindness, seizure, coma, agitation, confusion, and death. So, when it is combined with pentostatin, it has been associated with fatal pulmonary toxicity, so not recommended during the pregnancy. Another drug is cladribine. Cladribine is an another adenosine analog and uniquely combined of its action. Unlike other purine analog that inhibit DNA synthesis, cladribine inhibit both DNA synthesis and repair. So the drug is active against quiescent cells as well as cells that are actively dividing. Cladribine is highly active against hairy cell leukemia and considered as a drug of choice for this cancer. And it is also active against chronic lymphocytic leukemia, low grade non Hodgkin lymphoma, acute myeloid leukemia, mycosis fungoides, So the dose limiting toxicity is again the myelosuppression, and high doses can cause acute nephrotoxicity and delayed onset neurotoxicity. For patients with hairy cell leukemia, cladribine is administered by continuous IV infusion over 7 consecutive days. Nalarabine, another drug, but it is analog of guanosine, and the drug is used for patients with T cell acute lymphoblastic leukemia or T cell lymphoblastic lymphoma. The drug has not responded to at least two chemotherapy regime. Monotherapy with nalarabine can produce a complete response in some of these patients. IV administration is recommended, and it undergo the conversion to its active form, ARA-GTP. Incorporation of ARA-GTP into DNA then causes DNA fragmentation and subsequent apoptosis. Most common side effects include anemia, leukopenia, neutropenia, and thrombocytopenia, potentially fatal neurotoxicity, so manifesting as paresthesias, ataxia, confusion, convulsion, severe somnolence, and coma. The last drug is clofarabine. Clofarabine is a purine nucleoside analog, and it is indicated for relapse or refractory acute lymphoblastic leukemia for at least two previous regime have failed. IV administration is recommended, and intracellular conversion is required to its active form into clofarabine 5-triphosphate. The cell death occurs by several mechanisms, including termination of DNA elongation or inhibition of DNA repair or promotion of apoptosis, that is the programmed cell death. The dose limiting toxicity include bone marrow suppression, hyperuricemia, which may result in massive tumor lysis. Other reactions include tachycardia, fatigue, chills, fever, headache, itching, rash, diarrhea, abdominal pain, and pain in the extremities. Life threatening syndromes, that is systemic inflammatory syndrome and capillary leak syndrome, may also occur by the administration of clofarabine. It is teratogenic in rats and rabbits, so avoided during pregnancy and should not be used. The fourth class, which is considered as cytotoxic anti-cancer agent, is hypomethylating agent, and there are two drugs in this category. And basically, the hypomethylating agent inhibit the DNA methyltransferase, an enzyme that put methyl group onto DNA component. One of the important steps in DNA synthesis. So hypomethylating agent basically what have done addition of methyl group at DNA component. So it can inhibit the DNA synthesis or stop the process of DNA formation. So the two drugs which is included as hypomethylating agent, that is azacitidine and dactabine. The azacitidine is the first representative new class of anti-cancer drug hypomethylating agent. This is the analog of cytidine and incorporated into DNA by inhibiting DNA methyltransferase, which then put methyl group into DNA component. So the resultant hypomethylation of DNA is believed to induce apoptosis and restore normal function to gene critical to cell differentiation and proliferation. This inhibition of DNA methylation do not cause significant inhibition of DNA synthesis. Azacitidine has one indication, that is a myelodysplastic syndrome, a bone marrow disorder characterized by reduced blood cell count and the potential to progress to acute myelogenous leukemia. Toxicity include myelosuppression, nausea and vomiting, and CNS depression. Another drug, azacitidine, is an analog of cytidine, again that inhibits DNA methyltransferase, which lead to the same mechanism and indicated only for dysplastic syndrome. Toxicities are the same, just like myelosuppression, nausea, vomiting, and flu-like syndrome. And a single dose consists of 15 milligram per meter square infused IV over 3 hours. Regime consists of one dose every 8 hours for 72 hours, repeated every 6 weeks. So this is dacitabine and azacitidine. Now, the anti-tumor antibiotics will cover in the next lecture, inshallah. This is all about the anti-metabolites. Hope you will understand. And if there is any question, write in the comment section or may ask at my WhatsApp number. Thank you, class.